orthopedic and trauma specialist from NITO. In this pandemic situation where a contagious disease around us, we have to stay our home, and physical activity can lead to osteoporosis. So today I'd like to share my talk on basics and pathophysiology of osteoporosis. So at first, at the beginning, what is osteoporosis? It is literally, osteo refers to bone and porosis means the pores. So osteoporosis means when there is a higher breakdown of bone in comparison of formation of new bone, which result in a porous bone. So osteoporosis is a condition where bone mineral density decreases, and that leads to fragility of bone, which eventually leads to fracture. Prior to the widespread application of the bone mineral densitometry, osteoporosis were rarely diagnosed, and that time only there are suspicion where there is symptomatic vertebral fracture and osteopenia seen in radiology. For too long time, hip fracture at the end point of this metabolic disease were either thought it is the consequence of aging or ignored in respect of treatment. But after wide use of bone densitometry, WHO set a working definition for osteoporosis. What is that? The World Health Organization has defined osteoporosis as the T-score below -2.5 and defined osteopenia as a T-score between -1.0 and -2.5, whereas the normal bone mass as above -1.0. So we have to understand what is the T-score and what is the Z-score. When your score compares your result to a healthy young adult at age of 20 to 35, that is T-score, and when you compare your result as a person of the same age and same gender as yourself, that is Z-score. So after setting the working definition, it is easy to identify who are susceptible to osteoporosis and who are susceptible to osteoporotic fractures. So how we classify osteoporosis? Osteoporosis may be classified in two broad headings. First one is primary osteoporosis and second one is secondary osteoporosis. The another name of primary osteoporosis is involutional osteoporosis. And our main topics is today focused on the primary osteoporosis. The primary osteoporosis is again divided into two types. Type 1 is postmenopausal osteoporosis and type 2 is senile osteoporosis. And there are some secondary cause of osteoporosis like some endocrine disorders, some drug-induced disorders, some malignancy, nutritional disorders, and some idiopathic cause, and this very important cause, and which is prolonged bed rest and sedentary people who is less workforce, then that is another cause of osteoporosis. So when we go to the basic structures of a bone, basic structure of a bone, there is an external layer that is hard layer that is called cortical bone, and there is a soft internal layer named spongy bone or trabecular bone. The trabecular bone is composed of trabeculae, and the trabeculae are the structural beam that forms the framework of a spongy bone, and the cortical bone are made like many pipe-like units that is called osteon, and which run through the bone, and in the center of the osteon there are some hollow spaces that is called Haversian canal. That Haversian canal contains the blood supply and innervation of the bone. Around the Haversian canal, there are some concentric lamella which a bit like a tree. The lamella have an organic part which is most like collagen, and inorganic part which are hydroxyapatite crystal, mostly calcium phosphate. In between two lamella, there are some space which are called lacuna, which contains bone cell and called osteocyte. At the first glance, bone may appear an inert and unchanging substance, but bone is a very dynamic tissue. And this dynamism is maintained by bone remodeling process. Bone remodeling process is made up of two basic things. One is bone resorption and another is bone formation. So what is bone resorption? Bone resorption, in which a specialized cell named osteoclast break down the bone, and another type of cell named osteoblast, which is responsible for the bone formation. And this bone remodeling is highly dependent on serum calcium level. Serum calcium level, which in turn are kept in the normal range by a balance between parathyroid hormone, calcitonin, and vitamin D. Parathyroid hormone is produced by the parathyroid gland in response to low serum calcium level that increase bone resorption and release in the blood circulation. On the other hand, calcitonin is produced by the thyroid gland in response to high serum calcium, so it opposes the action of the parathyroid hormone, therefore promoting bone formation and decreasing bone resorption. And finally, vitamin D. Vitamin D promotes calcium absorption in the gut and thus increase serum calcium, promoting bone formation and decreasing the bone resorption. So the result between these homeostasis caused a specific thing which is very important in the topic of osteoporosis, that is peak bone mass. So when we deal with the peak bone mass, we have to understand what is the peak bone mass. Bone mass accretion starts from the childhood and continues in the adulthood, usually occurs earlier in the female than male. Peak bone mass can be achieved in the mid-20s for the spine and hip, while other bones such as radius reach a peak at the age of 40 years. After that, bone mass normally declines. There are some factors which are determine the peak bone mass. And first one is genetic factor. For example, people of African descent tend to have greater bone loss, bone mass, and nutrition. Second one is nutrition. Adequate vitamin D intake can increase bone mass. And a very important factor which is very much necessary in this pandemic situation, that is physical activity. And physical activity increases the bone mass. And finally, some hormones like estrogen and androgen that inhibits bone resorption. So now, when osteoclasts break down bone faster, then the osteoblast can rebuild it. It results in the lowering of the bone mass eventually, which leads to osteoporosis. If we look to the slide, microscopic section, cross section of a osteoporotic bone, it will show normal cell with normal mineralization. But which is differentiated from the osteomalacia, where there is lack of mineralization. So abnormal microscopic finding of osteoporosis is fewer trabeculae in the spongy bone, thinning of the cortical bone, as well as widening of the Haversian canal. The bone changes, increasing the risk of fracture. These fractures are known as fragility fracture or pathologic fracture. Some bones like shoulder bone, vertebra, and ribs consist of mainly spongy bone, so they are at the great risk of fragility fracture. So now I am discussing about the main cause of primary osteoporosis, that is postmenopausal osteoporosis. Before going to the postmenopausal osteoporosis, we have to understand what is the role of estrogen in the bone physiology. There is a protein named rank ligand promotes the activation, differentiation, and survival of the osteoclast via interaction with its receptor named rank. When a rank ligand activates a osteoclast, it resorbs the bone. So what is the role of estrogen on this matter? Estrogen down-regulate the rank ligand signaling, which decreases the rank and subsequent decrease of the bone-mediated bone resorption. So estrogen also have been shown to stimulate the expression of osteoprotein, a hormone which inhibit a protein which inhibit the activity of the rank ligand by preventing it interrupting with its receptor. So in menopause, when the estrogen level decreases, rank ligand production is increases, so increase of the bone resorption. Increased bone resorption lead to accelerated loss of bone mineral density, which can result in the most severe condition called postmenopausal osteoporosis. And another variation of osteoporosis is senile osteoporosis. Senile osteoporosis is the osteoporosis that is believed that osteoblasts are gradually lose the ability to form bone with the process of aging, but osteoclast doing to keep it work. So bone resorption usually overtakes the bone formation, and it occurs around the 7 to 8 decade, and it is called senile osteoporosis. So when we summarize the risk factors of osteoporosis are, we can memorize it by a mnemonic name access, that is alcohol overuse, corticoid, some drug like corticosteroid, heparin and levothyroxine, low calcium level, low estrogen level, smoking, and sedentary lifestyle cause the risk factor of the osteoporosis. There is a study on primary osteoporosis that suggests that the achievement of peak bone mass is the most important to the bone health and plays a vital role in preventing osteoporosis and subsequent subsequent fracture in the later years. So not vitamin D, not anything. It is the peak bone mass which is very much important for the prevention of the osteoporosis. And they suggest that hip fracture could be reduced by 30% with an increase in the peak bone mass 10%. I want to conclude with a poster published by World Osteoporosis Foundation. They advise by taking regular action through your regular exercise, a bone healthy diet, and consulting your doctor about the risk of osteoporosis, and avoiding smoking and alcohol can protect your future by not to fracture your bone by osteoporosis. That's all from my point about the basic pathophysiology of the osteoporosis. Thank you, sir.
Thank you, Dr. Shubha, for your nice derivation of your presentation. And now I would like to introduce you to our new guest, Professor Dr. Mohammad Anwarul Islam, sir. He is the General Secretary of Bangladesh Spine Society. He has just connected with us. And to our learned audience, please put your questions. You can address this question with speaker or with our panel of experts if you like to. Just put your questions in the comment section so that I can collect those questions and transfer those questions to our speaker. Now I'd like to request Professor Shahidul Islam sir to start his presentation. Thank you very much, sir. Sir, you need to unmute yourself, I think. Professor Shahidul Islam sir, sir, you need to unmute yourself. Sir, you need to unmute yourself.
Okay.
Okay, thank you, sir. Yeah, we can hear you now.
Can you see my presentation?
Yeah, we are seeing your presentation. It's nice. Okay, you can start, sir.
So thank you, Dr. Kaisar Rabbi, the moderator. And I would like to express my thanks and gratitude to our honorable chairperson of the session, Professor F.M. Ruhul Haq, MP, who is the ex-successful Health Minister of the Bangladesh, and our panelist, Professor Dr. Khandokar Abdullah Rizvi, the President of Bangladesh Spine Society and ex-President of Bangladesh Orthopedic Society, as well as the ex-Director of NITO, Professor Ashrama A.S.M. Jahangir Chaudhary Tito, is the ex-principal of Faridpur Medical College, and Dr. Anadi Ranjan Mondol is also the Assistant Professor of Faridpur Medical College. And my previous speaker nicely and elaborately has described the pathophysiology, and he has given the definitions also. I will continue with with him, and there may be some overlapping. You can, this is also he defined already what is osteoporosis, and according to World Health Organization, he said that also referred to as T-score of minus 2.5 is osteoporosis. I have to find out this. I'm very interested about the osteopenia. When this T-score is -1 to -2.5, this is osteopenia. We are usually say osteopenia. I want to like to say this is less bone mass. This is bone mass is decreased because he is or she is going to osteoporosis. We have to check this portion also. And you see regarding the epidemiology, especially in Bangladesh and India, actually the prevalence of osteoporosis remain unknown because of the asymptomatic nature of this disease. In India, it has been postulated that 35% of the postmenopausal women are at the risk of developing osteoporosis, and osteoporotic bone fracture commonly occurs. Commonly occurs at the vertebra, hip, and wrist. All of you know. On an average, a postmenopausal woman has 40% to 50% chance of developing fracture, including 15% chance of hip fracture in her lifetime. Very interesting. More than 10% of the hip fracture victims die within 1 year from various complications. And nearly 50% of the survivors are incapacitated, some of them permanently. So this is very alarming situation. Regarding the global concern, all of you know 1 in 3 women and 1 in 5 women is suffering from osteoporosis who are above 50 years of age. And 15 to 30% men and 30 to 50% women suffers fracture related to osteoporosis in their lifetime. So already Shubha Prasad has said, we attain the peak bone mass. And this is the main period. I want to say first time. Sometimes we people are incoming for our future. When there will be no job, we will be idle. We have to spend money for that time. I want to say that you deposit your bone, attain the high peak bone mass for future. So those you should have not developed osteoporosis, or you should not develop any fragility fracture. So there is a consolidation period, he said, and this is a sudden fall after 45 years, when menopause starts. And you can say there's a sudden fall and it crosses the fracture threshold. This is very important, and therefore the fragility fractures occurs. He has already said what are the risk factors like Caucasian race, advanced age, female sex, and premature menopause, that is before 45 years, and prolonged time of about more than 1 year without a menstrual period, short or undersized person, and operative removal of the ovary is one of the important causes, especially in our country. If you go to periphery, you will find many ladies have no ovary. So these factors are modifiable, non-modifiable. We cannot change, but there is modifiable factors. That cigarette smoking, excessive alcohol intake, inactivity, like this pandemic period, we are all of inactive remaining within our home. Low body weight is very important. Patient can develop osteoporosis, and poor general health and prolonged immobilization and long-term taking of steroid. So how to assess the osteoporosis? We the physician usually called osteoporosis as a silent killer. because it does not produce any symptoms. We can see only the tip of the iceberg, but maximum portion remain obscured. We cannot see, and patient cannot present and have no history of any symptom. For these reasons, most of the osteoporotic patients are usually not identified in our society. We have to look for the risk factors already told, and the family history. There is a genetic predisposition, and we have to take the medical history, especially the low back pain, when there is a height loss, or there is a change of posture, or if there is any fracture, especially fragility fracture. So Prasad already said fracture neck fiber, vertebral fracture, wrist fractures, proximal humerus fracture, etc. And in this case, we have to examine the patients and we should go for some laboratory investigations. But already my previous speaker told you that BMD testing is the gold standard for the diagnosis. So we have to keep in mind some differential diagnosis. These are the secondary cause of osteoporosis, already hyperparathyroidism like this, but also Paget's disease, osteomalacia, osteogenesis imperfecta, multiple myeloma, secondary tumors, sometimes confused with osteoporosis. We have to keep in mind. For these reasons, we have to go for some routine investigations, especially some blood count, sedimentation rate, C-reactive protein, serum calcium, albumin, creatinine, phosphate, alkaline phosphatase, and liver transaminase for the secondary cause of osteoporosis, and thyroid function test, and lateral radiograph of the lumbar and thoracic spine. And the standard is the bone densitometry. We have to go for other investigations also, like serum protein electrophoresis, urinary Benzone's protein, serum 25 hydroxy vitamin D. I will come later on. Plasma parathyroid function, serum testosterone, sex hormone binding globulin, follicle stimulating hormone, luteinizing hormone, serum prolactin, and 24-hour urinary free cortisol or overnight dexamethasone suppression test, and markers of bone turnover and urinary calcium excretion, and other many investigations we have to go for identifying secondary osteoporosis and for differential diagnosis. So X-ray previously, or my previous experiences, this was the golden standard. During my studentship, I found that X-ray, with the X-ray we diagnose the case of osteoporosis. But osteoporosis produces increased radiolucence of the vertebral body. Approximately 30 to 80% of the bone tissue must be lost before recognizable abnormality can be detected on spinal radiograph. But it depends on the quality of your machine, depends on the quality of the technician, depends on the size of the person. If the size is obese, we cannot detect the bone quality. So these are the fractures already my previous said. Previously, we used this Singh index for diagnosis of osteoporosis. Nowadays, it is not easily used. Just for recapitulation, I put this figure in front of you. There are some screening tests available in our country, and many people did this screening test, but there is a problem, like quantitative ultrasound and peripheral quantitative computed tomography. This is also called peripheral test, but no one technique serves all the functions of skeletal assessment, including diagnosis, prognosis, and monitoring of the treatment. Only BMD can do everything. So we need to BMD. This is dual energy X-ray absorptiometry for BMD. This is the machine. Remember that when we will go for the follow-up of the patient, you should have BMD from the same machine, by the same technician, and by the report by the same physician. So you can compare them. So the International Society for Clinical Densometry said that femoral neck is the predictive value for the fracture risk, and spine for assessing the response of the treatment. Everybody, when we advise for BMD, we get this type of picture, and we can calculate from here that the patient develop osteoporosis or osteopenia or normal. Who should go for testing of BMD? This is very important question. If you cannot send everybody to this for this test. The candidates are older than age 65 years, regardless of the risk factors. But in United States of America, they told 65 years in case of female and 70 years in case of male. But postmenopausal women and have at least one risk factors for osteoporosis, including having a fracture of the bone, having vertebral abnormality like kyphosis or low back pain already said, and use medication like prednisolone that can cause osteoporosis. Type 1 diabetic patient with liver disease, kidney disease, thyroid disease, or a family history of osteoporosis above 50 years. Study is done in NATO, Dhaka Medical College and KR Medical College Hospital between January 2018 and December 2018. Number of the patient was total 200, male was 91 and female was 109. And we found that rate of osteoporosis, you can see here, the 35% in our study, 30% people over 50 years of age having no abnormality, we found osteoporosis. And 41% osteopenia. So total 76% patient has osteoporosis and osteopenia. I think it is alarming for our country. So in our study, 1 in 2.2 female and 1 in 4 male suffers from osteoporosis. But in international study, it is 1 in 5 male and 1 in 3 female, already told. We did the study also that what is the status of vitamin D, that there is a lot of talk about the relationship of vitamin D and calcium with the development of osteoporosis. You can see here that there is a deficiency of osteoporosis, a deficiency of vitamin D in 63%, 63% patient, and insufficiency 23%. At total, 87.5% patients below the level 30 nanogram, below the level, and 63% deficiency of vitamin D. But we find no association found between the osteoporosis and serum vitamin D. You see here, the normal patient 36% develop osteoporosis, in insufficiency 32%, and deficiency 37%. So there is no statistical difference between the deficiency of vitamin D and normal vitamin D level. So there is no association like this. In our study, about 200 population, we found only 6% patient, only 6% person have low calcium and one is high calcium. So only 7% patient is abnormal calcium level. And we found no association with between osteoporosis and calcium deficiency or normal. So this is interesting to me. So rate of osteoporosis, this is interesting that 52.4% patient develop osteoporosis who belongs to the age of more than 70 years and less than 60 years, 24.5%. So this is a good news. Now, how we'll go for managing the osteoporosis? There is a National Osteoporosis Guideline Group developed this management protocol in 2017 and updated in 2019. You will find it. These are the group or other organizations that develop this, and you can find this on the website. And they say we will go for BMD, assessment of fracture risk first. Because why we are afraid of osteoporosis? Because there are chance of fragility fractures. In case of postmenopausal woman and in case of man over 50 years, we should go for WHO fracture risk assessment tool. But unfortunately, for our country, there is no such tool available in the website. This is for some developed countries. We can put all this data here and we can find the assessment of fracture risk for 10 years for hip fracture and other bone fracture by using this one. This is not available in our country. So vertebral fracture can be considered, assessed with the patient of postmenopausal woman, men over 50 years, If there is a more than 4 centimeter height loss, is the patient has kyphosis and having oral steroid, and BMD T score is less or minus 2.5 standard deviation. So how we prevent or treat osteoporosis? Very important is non-pharmacological treatment. Very important. We should consider about diet, physical activity, and which we can avoid easily, especially in our country. Please avoid smoking. Many of our doctors is habituated to smoking. Avoid soft drink and caffeine. There is controversy about the caffeine. If you take caffeine, you have to take vitamin D side by side and calcium. So avoid alcohol. Fortunately, we are not habituated, our nation is not habituated to the alcohol. And you have to go for sun exposure and avoid steroid, anticoagulant and antiepileptic drug if possible. If not possible, we have to go for another treatment protocol. And please avoid, try to prevent fall of the senior people. What is about diet? First of all, we should take a balanced diet, which must contain sufficient amount of protein, 1.2 gram per kg per day. Especially these men and women over 50 years of age. Calcium, 1200 milligram per day, not more than 200 milligram per day because there may be some side effects. And vitamin D, 800 international per day for this. Not for younger group. This dose will be less. And we should take this type of diets which are rich in vitamin D and calcium. If we need it, if we go for investigation of vitamin A, then we can supplement. And if we can get from this amount of vitamin and calcium, we don't need to supplement them. What is the role of exercise? And what type of exercise we should do? Walking, running, jogging, jumping, and jumping rope. Best one is running, jumping, and jumping rope, jogging. But is it people? It may not be possible. So walking, at least walking. And time frame should be 30 minutes daily. Somebody says 5 days in a week. If possible, 30 minutes daily. This is also for prevention of osteoporosis. What I am telling now, the diet and this exercise, this is also for the prevention of osteoporosis. What does weight-bearing exercise do? It improves bone mass, directly stimulates osteoblast for new bone formation. Muscle strengthening exercise, especially stretching exercise or carrying weight in hands or resistance exercise. The muscle attaches with the bone is stimulated and the new bone formation occurs. And it also improves the balance so that the person cannot fall easily. Don't stop your exercise. If you stop exercise, suddenly bone mineral density will fall. I have to introduce one term, probably new to somebody, the sarcopenia and osteoporosis run hand to hand. Sarcopenia means age-related loss of muscle mass, strength and functionality. So if it happens like that, it will be a problem and patient must develop osteoporosis. Try to prevent the fall of the aged persons. How will you do that? Exercise like balance training exercise, lower limb strengthening exercise, correction of sensory impairment like correction of low vision and hearing impairment, reduce environmental hazard, appropriate reduction of medications which can provoke to fall the patients, appropriate education of the patient, and you can give some measurement in your home. Use handrail on stairs and also at the bathroom where there's aged person. Keep floor clutter free. Keep the floor clean but not slippery. Use rubber mat in the bathroom or in front of the bathroom or where there is a tub. Use rubber mat. Use a 100-watt bulb in all rooms so that these aged people can see and can work. So who should be considered for the treatment by pharmacological agent? Postmenopausal women and men aged 50 years older presenting with following should be considered. Number one, a hip or vertebral fracture. How I can deteriorate? Clinically apparent or we found by imaging. T-score minus standard deviation minus 2.5 or more than minus 2.5 at the femoral neck, total hip or lumbar spine. Low bone mass, that is T-score minus 1 and minus 2.5 standard deviation at the femoral neck or lumbar spine. A 10-year probability of the hip fracture is about 3 or more percent, or a 10-year probability of major post osteoporosis related fracture is 20% or more. It can be assessed by using facts, but which are not available in our country. What are the pharmacological agents available in our country and we can use? Bisphosphonate, one of the gold standard treatment, and denosumab, hormone replacement therapy, estrogen-like mediators like selective estrogen receptor modulators, SAMs like raloxifene, tamoxifen, and this is I'm going later on parathyroid hormone analog like teriparatide, and this is the red mark I guess this abaloparatide. It is yet not approved by FDA in case of high risk patients, and calcitonin. These are the drugs we use. Bisphosphonate is widely used in our country, also in another part of the country, in another country also. These are the analogs of pyrophosphate and bismuth 2 pyrophosphate attached together and causes apoptosis of the osteoclast by disrupting the cytoskeleton. It occupies the site of whose site for the osteoclast and reduce the osteoclastic activity as an process of the osteoclast, and thereby inhibit. What are the bisphosphonate? These are the third generation bisphosphonate is not used nowadays. These are the second generation, alendronate, abandronate. These are the second generation bisphosphonate. And residronate and zoledronic acid are the third generation bisphosphonate. You know the dose of alendronate 10 milligram daily tablet or 70 milligram weekly for the treatment. And abandronate 150 milligram monthly tablet. And residronate 150 milligram monthly tablet or 35 milligram weekly tablet. And zoledronic acid, basically personally I prefer zoledronic acid because of the dose convenient, and we can give follow-up only after 3 years. And if we give oral bisphosphonate, we have to give for 5 years, but zoledronic acid for 3 years. What are the side effects? Side effects for all oral bisphosphonate are gastrointestinal problems such as difficulty in swallowing and esophagitis, gastritis. For this reason, we advise them to take the drug in the empty stomach in the morning, or at least 1 hour before the intake of food, and remain standing or sitting, not to lie. All bisphosphonate are contraindicated in patients with estimated GFR below 30 to 35 ml per minute. You should remember that. Osteonecrosis is one of the complication of bisphosphonate and side effect of bisphosphonate. Another is low trauma atypical femur fracture, usually the proximal part of femur. This is the common side effects. And teriparatide. Teriparatide is one of the well-known drugs used in different countries, especially in America. It is the parathyroid analog and approved for the treatment of osteoporosis in the postmenopausal women and men at high risk fracture. It is also for the treatment of the patients who cannot avoid glucocorticoid therapy, and we usually prefer this for this drug. Dose is 20 microgram daily in subcutaneous injections, but it should not be continued more than 2 years, 18 to 24 months. If you stop it, you will go for anti-resorptive drugs like bisphosphonate. There are some already I have said, selective estrogen receptor modulator drugs. So this is the raloxifene, 60 milligram per day, but it has some side effect like deep vein thrombosis and hot flashes of the leg and leg cramps. Calcitonin, you can use calcitonin, but there is some complication of calcitonin. You know, calcitonin is produced by the thyroid gland, and the dose is 200 international unit delivered as a single daily nasal spray, but it can cause rhinitis, epistaxis, allergic reactions, and even cancer. I don't like to this calcitonin. So this is one of the beautiful drug. Already my previous speaker says rankle inhibitors, denosumab. Uh, Somebody like donisumab, but it should be denosumab. It occupies these are the denosumab. You can see the figure. These are the denosumab. Is occupies this rankle. Already you said this rank ligand and occupied, so it cannot this rank ligand this rank ligand is produced this by osteoblast, and is they occupied this rank ligand and it cannot bind with the osteoclast precursor, and they cannot combine fuse with each other and cannot form. Ultimately, they are not able to destroy the bone. This is the new update. Came in 2020, romosozumab, but still the FDA deliberation has had some cardiovascular problem and some also cardiovascular incidents may occur. In this case, it is not widely used. The dose 210 milligram monthly subcutaneous injections for 12 months. The pharmacological intervention treatment should be reviewed 3 years after zoledronate acid, already I've said, and 5 years after oral bisphosphonate, and continuous phosphonate therapy is needed more than 75 years if there is a hip or vertebral fracture or patient taking a steroid. The osteoporosis for men, alendronate or recidonate is the drug of choice, but you can use the intravenous bisphosphonate and denosumab also. Dear friends, this is the our beautiful memory. This is the first National Institute of Traumatology and Orthopedic Rehabilitation. Our chairperson, he was the president of Bangladesh Orthopedic Society as well as the director of NITOD. This building was there. And I must give thanks to the Honorable Prime Minister Sheikh Hasina that after our request, our then director, one of these panelists, Professor Khandukar Abdullah Rizvi, followed by Professor Iqbal Kabi, and followed by current director, Professor Abdul Ghani Mullah, they tried the level base to develop a new building here and addition of extra 500 bed and now the totally 1,000 bed hospital. So after demolition, when we decided to break this, we seen that after some trauma by bulldozer, it breaks like that. This is called osteoporosis. And you can build it, rebuild it. This is like that. So we are very grateful to them, the Honorable Prime Minister, then the ex-health minister, and the directors named and said, this is our new proud of NITOR, addition of extra 500 bedded hospital, total 1,000 bedded, and the largest hospital in the orthopedic hospital in the world. Love your bone, protect your future. Thank you for your patient sharing, and thank you.